You're listening to Medscape's In Discussion series on cancer survivorship, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Ann Partridge, professor of medicine at Harvard Medical School, vice chair of medical oncology, founder and director of the program for young adults with breast cancer, director of the Adult Cancer Survivorship Program, and Eric P. Weiner, MD, chair in breast cancer research at the Dana-Farber Cancer Institute. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Ann Partridge from the Dana-Farber Cancer Institute. Welcome to Medscape's In Discussion series on cancer survivorship. Today, we'll discuss sex and cancer survivorship, an important topic, although not as discussed generally as it probably should be. But first, let me introduce my guest, Dr. Karen Winkfield. She's the Executive Director of the Meharry Vanderbilt Alliance and a Professor of Radiation Oncology at Vanderbilt University. Welcome to In Discussion, Dr. Winkfield.
Thank you so much, Ann. It's so great to be here. I actually was hoping that we would have the intro, let's talk about sex from Salt and Pepper. We can have that music playing because this is such an important topic. Thank you so much for having me today.
No, I appreciate that. And I did almost sing it out to you, but it's a good thing I have a day job, Karen, because you would learn very quickly, as would our listeners, that there's a reason I veered into the biology and away from the chorus. All right. So, Karen, tell me, I like to ask each of the guests on this series, what drew you to this particular issue in your practice and your research for patients?
Well, I tell you, we don't talk about sex enough. And I remember, this was a couple of years back. This is actually when I was at Harvard. So it was in Boston at the time, and had a young woman that I was doing some community engaged work with. We were at a church function. She was, I think, 31 at the time, and had mentioned to the church group that we were talking with, that she was a breast cancer survivor, and one of the things that people didn't talk about is sex. And what is it going to be like for her as a young woman who had just gone through breast cancer treatment to date? And it blew my mind because I don't remember having any training as a medical student to talk about sexual health. I didn't remember as a trainee in radiation oncology talking about sexual health for patients who had gone through cancer care. And it just made me think, wow, we need to do something different. That was for breast cancer, but I also remember having patients when I was doing brachytherapy for women with endometrial cancer, for instance, and they get the vaginal cuff brachytherapy. And we do pay more attention as radiation oncologists to those women in terms of making sure they have some supports around their vaginal health. But I don't know that continues all throughout survivorship. So it's really an important issue. And it's one that I think we need to be reflective of, because every single treatment we give, every cancer therapeutic, has some toxicity or side effect, and oftentimes has a sexual side effect that we might not even think about.
Yeah, I think that you hit on a really important point. This is relevant for all human beings, to be honest, as cancer survivors, and that includes people going through treatment. Here, this isn't just about people who are living with the aftermath. I think people living with chronic cancer or going through treatment, they're equally survivors in this arena in terms of wanting to have full lives, and sex is a huge part of people's lives. And you alluded to, especially I think in our young adult populations, where they may just be taking off, or they're in their quote unquote prime.
Right.
And so it can be a bigger issue there, because as we know, that's the way our society works too. People are judged differently. So it's not just about whether the organs work or whether they have a side effect. It's about how people feel and how they look, which of course we know that cancer and cancer treatment impacts tremendously.
Oh, absolutely. And I was thinking that some of the literature, when you look at how often patients are even asked about their sexual health, it's actually quite embarrassing from an oncology perspective that probably fewer than 30% of providers in the literature, when you look at some of this stuff, have actually asked the question about sexual health, even in the setting where they know or they have suspicions that a greater number of patients are having these issues. And I do think it's related to that bias, right? So whether it be younger age, I do think that there may be a little bit more awareness, certainly for patients who are going through therapies that might impact their fertility. We talk about fertility, right? Oftentimes sex, it might be part of that. But what about for older adults? I think sometimes we're biased even saying, well, they're older, so we don't need to have that conversation. But look, as I get older, I'm like, this is something we need to start asking all of our patients, regardless of what they look like, what kind of their interest is in the topic, and making sure we can send them to resources that may assist.
Yeah, I think you make a really good point about not neglecting any population, because I think you're right. It's a huge issue in all of our survivor populations. Let's drill down, though, a little bit into, are there specific populations that have more need or where we should address things more proactively? Although I do agree that everybody should be screened for this and it should be brought up. You talked about the gynecologic malignancy patients who are getting radiation in particular. You know, one of the things that our sexual health expert tells us is that just handing someone a bag of dilators and saying use them is not good enough. And that still happens, which is, at least they're handing the dilators, but,
Yes.
are people being informed about that? How do we help those patients, or at least the systems, to better educate people and support them?
It's such an important question. I think as medicine changes, we've moved away from having the providers oftentimes be the ones who are doing long-term survivorship care, right? So there's education that needs to be done, particularly around downstream. So if indeed the person who has treated a patient is no longer going to be handling their survivorship care, and maybe that transition happens 4 months out or 12 months out or 24 months out, regardless, this issue of sexual health is one that has long-term consequences. We need to continually be asking these questions. And so if indeed there's a survivorship provider, whether it be an advanced practice nurse or other provider, a PA, who's going to be handling those survivorship questions, we need to do education. Because that's one of the issues is oftentimes providers, like I said, I myself didn't get a whole lot of education around sexual health and well-being and what things we might need to address with our patients. Imagine even more so for individuals who might be taking care of patients after active therapy. So I think there needs to be some education. We need to make sure our primary care docs are also educated on these issues, but we need to also empower patients to ask the questions. This is their body. They're the captains of the body. And sometimes they may just need to be upfront and saying, hey, I want to talk about this. This is an issue that is meaningful to me, but we also need to have awareness that some cultures, it's not appropriate to talk about these issues, or they haven't talked about sex, even in general, growing up, and even more so with their providers, there may be some hesitancy to bring up this topic that absolutely impacts their health and well-being, but they may be afraid to bring it up because of cultural issues.
So do you have suggestions or how we do that with someone? And I realize there are lots of biases that we providers bring to the table when we address many things. Suggestions for if you get the sense that it's maybe a taboo area for someone, but you want to make sure they're okay. How do you do that?
I think the first thing you do is ask the question. I think there's two things. We need to reprogram ourselves as providers to actually just ask the question, regardless of who's sitting in front of us. How's your sexual health doing? And if there's a blank stare, how about your intimate health? How's your intimate well-being? Because here's the thing. Not everyone has sexual intercourse. Intimacy is impacted by cancer therapeutics. And you think about some of the side effects and toxicities of our treatments, whether it be immunotherapy or surgery, et cetera, that can impact our physical well-being. It's not just about the act of having sex, but there's the intimacy piece. What about being fatigued? Sometimes people are just too tired to be intimate with people, and intimacy might just be going to dinner with friends, okay? We're not just always talking about the act of intercourse. And I think that's really important to just even ask people if their quality of life is being impacted. So I do think we need to, whether it be have a script or figure out how to ask people about their sexual health or their intimate health or well-being, it's just something we need to do as providers. And sometimes just opening that up. will allow individuals who may be from backgrounds where it might be taboo to actually say, well, actually, I'm having a little bit of issue with intimacy. And so we can, you say, well, tell me a little bit more about that. And if they get shy, make sure there's nobody else in the room, because sometimes they need to have that space to just have that personal one-on-one conversation without having an audience in the room. And it also is helpful, I think, to teach staff. So nursing staff can sometimes do a little bit better job than oftentimes with the doctor, that doctor-patient relationship, because some patients still see that hierarchy. Sometimes having a nurse kind of come in or an APP, it's really important to kind of have your team have awareness around this issue. It was one of the things that we did in Rad Onc when I was at Mass Generals. We actually had a nurse. There's unfortunately a little bit of a bias in terms of how often women get asked about their sexual health versus men. But these were men in the prostate cancer clinic. But we had our nurse practitioner actually go in and ask the questions. And believe it or not, she's a woman, but she had a lot better opportunity to ask those questions because she had more time. And it was a specific conversation that she was well educated to have with the men who are in that practice. So I do think that, number one, just asking the question, regardless of what that person looks like, regardless of whether you think there might be a taboo, but if you notice that there might be some hesitancy, this is where we use our skills as providers. We ask them, are you uncomfortable with this? It's okay to ask the questions, but this means we need to be looking at people. And I find a lot of providers are sitting on their computers typing. So that's just my own thing. The practice of medicine, it really does require taking a little bit of time to allow patients to have that space and let them know that you're concerned. That does take a little bit of eye-to-eye, face-to-face contact.
Yeah, open the door and allow them to talk or not. I do routinely ask people, and sometimes I ask so often that people think that this is the only thing I do. I'm probably an extreme. I think it's just so important. And so one lady, she looked at me and she said, I think you Americans care more about sex than we do. She was stereotyping. I said, I don't know about that. I think plenty of cultures care about sex.
But that's why, again, I think sometimes not just framing it about sex and sexual intercourse and thinking about intimacy, that may be another way, right? Because intimacy goes beyond just sexual intercourse. It is the interpersonal relationships. And to me, that's part of sexual health, is really kind of that conversation. And so that brings in fatigue and relationships, et cetera.
Oh, that's great. And do we see specific problems in some of our minority communities, whether it be racial, ethnic minority groups or LGBTQI or other groups? What are the data out there and how can we help in that arena?
Well, there certainly is the cultural piece when it comes to communities of color. I think that's where having just the wherewithal as providers to ask the question and open up that conversation will help, because there is a little bit of stigma that's attached to having conversations about sex. Some of it's based on religion even, where that's a taboo topic to discuss. We know there are disparities across the board, particularly for African Americans and definitely for Hispanics or people who are non-English speaking with respect to gaining access to resources. So you yourself as an oncologist or a provider may not feel like you have the expertise, or maybe they need some additional counseling. For instance, let me give you an example. That patient that I mentioned who was a breast cancer survivor and was very open talking about her issues related to her sexual health. Her biggest issue was body dysmorphia. The surgery left a scar, right?
Inside and out is what I tell people when we talk about it.
Yeah. So for her to have to be reminded every day that she went through cancer treatment was difficult, but it also impacted how she interacted with other people, despite the fact that when she's fully clothed, you wouldn't know. And this is where these issues can be so silent, and silence is deadly, frankly. And so this is where I think it's really important to talk about these things, but know that body dysmorphia is difficult. And so as an oncologist, I'm not prepared to help somebody with that. You need to make a referral to psychiatry or to some sort of counseling service to help people deal with those issues. And so this is where, unfortunately, I think communities of color are going to suffer more because they don't have access to healthcare in general for the most part.
Right.
You know, we know Black women don't even get referred for radiation therapy the way that they need to. So you can imagine a specialty service or sex counselor. That's probably going to fall by the wayside. And then think about folks who English might not be their primary language. So here we're talking about that cultural piece about even just having the conversation. What if English is not their preferred language? So they speak English with you and they can say, oh, I'm having some issues. But what about if they really want to have a discussion about their sexual health with someone who speaks their native tongue? That's a major challenge. And the other thing, you mentioned the LGBTQ plus community. Let me tell you, the trans community is one of the most underserved communities across the board when it comes to cancer care. There's a lack of understanding about who they are as individuals, understanding just to simply ask what their preferences are. Right? How would you like to be referred to? What's your pronouns? Those sorts of things. And we're getting better. But if an individual has a prostate, there needs to be discussions about prostate health and sexuality. If an individual has a vagina, that needs to be discussed. If there's been surgery, the issues around sex and sexual health need to be discussed. As an oncologist, I think there are lots of folks who'd be very uncomfortable having a conversation with the LGBTQ plus community about.
You mean the oncologists? Yeah, the providers.
Yeah, the providers. We're going to struggle.
And also it takes time. You have to actually be in the room with the person, be willing to spend a little time on this. And our current system, not to blame, point fingers in other directions, but I think it is challenging for our colleagues to fit all this stuff in when they're trying to make sure they're also not having a recurrence or they're managing the toxicities. But I think the implications of sexual dysfunction and larger intimacy and body image issues, as it's going to take a huge toll on people's mental health and their families and loved ones. So it's often more than just the patient, right?
Absolutely. And you bring up a good point. There was an article that actually did a survey of oncologists to say, how are you doing with sexual health in these conversations? And they do say the patients that I'm seeing have other problems that the provider considers more important. Doesn't mean the patient considers it more important, but the provider's like, wow, this person has metastatic disease. I'm handling that. I don't have time. The issues related to sexual health are secondary, or I need to make sure they're taking their AI. And then the second most common reason why these conversations are not had is time. So to your point, when you're trying to stuff relationship building and all of that into a 20-minute conversation, it's really difficult. And so this is where even, again, creating a team, having APPs or other providers to assist would be helpful. But certainly, even just asking the question, do you have any concerns about your sexual health? They say yes. What resources do we have to point people to? Doesn't mean you have to always be the one to counsel them, but just asking the question, that takes 2 seconds, right?
Yeah. And plugging them in. You're reminding me, we developed an intervention for our young women with breast cancer, and we enrolled 30 patients. So we did a small pilot where we're using a web-based portal to help to support women to self-manage some of their symptoms and concerns. And we enrolled 30 people. 10 had metastatic disease, 10 had early stage disease and were early on in treatment, and 10 were living as survivors with NED, no evidence of disease. And guess what? The most endorsed across the board symptom or concern was for all three groups, whether they were living with metastatic disease, newly diagnosed, or survivors.
Was it sex?
Sex. It was their sexual health. They all triggered the sexual health information that they get fed back in the portal, and we'll track them over time. We don't have those data. But it's fascinating that this is pretty ubiquitous, at least in a group. These were women 45 and under at diagnosis or living with the disease. But I would imagine if you pooled a group of prostate survivors or people living with disease or lung cancer patients, yes, people are, suffering from other things, but they still want to have good sex.
Right.
Which is what I've told my colleagues when we focus on this in education forum.
Yes, absolutely. And I think, to your point, it's across the board. It's not specific to cancers that just impact the sexual organs. And breasts are a sexual organ, folks. We've got to get that out of our head that they're just there to feed babies, So I think it's important to remember that that is a sexual organ. The breasts are, in addition to the genitalia, but certainly individuals who have other cancers. I think about patients who have sarcoma. What if you lost a limb? What does that do to how you're thinking about yourself and your body and what your concerns are related to your partner. So even the partner counseling can sometimes be an important thing that we oftentimes don't think about. Well, I'm not treating that patient's spouse, but their spouse is really important, or their partner is really important to their well-being. And so I love the fact, again, that we're having this conversation, because it's one that we just need to do a better job at focusing in on. And again, I sometimes like to use the word intimacy versus sex. Well, but you're right. I mean, there's this human need for sex. Do we have education around orgasms and all of that? These are things that, frankly, I didn't get any education on. I think we're doing better. There was an article that came out that had interviewed fellows and trainees, and some are getting some training on sexual health, which is great, including the importance of orgasm for populations, for the sense of well-being, for individuals. These are important quality of life things that we need to discuss.
So in our final couple minutes, what are the resources we can steer people towards, either for patients or for providers, for how to better support our patients?
I love that you're talking about resources. It's so vital, because we are overwhelmed as providers. Oftentimes there's so many things going on, so many things we have to do. And then to say, okay, now you want me to know how to counsel someone on their sexual health. No, that's not the point of this discussion. It's, can we ask the questions, and how do we point people to appropriate resources? I just want to highlight the fact that, look, there's so many factors that go into this sense of lessening sexual desire, or the changes in terms of enjoyment of sex or intimacy. That includes fatigue, menopausal symptoms, right? Women have been on chemotherapy that may kind of impact their ovarian hormonal functions. There's anxiety. There's fear. Even the fear of recurrence can impact a person's sexual desires. Depression, weight gain, which we definitely see, right, in our breast cancer patients who are going through hormonal therapies. There's grief that is associated with just having a cancer diagnosis. And so these are all components of survivorship, irrespective of whether you're still in treatment, you have metastatic disease, you have ongoing therapy. These are all components of survivorship that we've got to pay attention to, impact other areas of our life, but certainly impact sexual health as well. So I just want to state that in general, I think as oncologists, the survivorship piece seems a little bit unwieldy because there are so many components to it. And this is where having that team approach is really important. Who's on the team? Who can you point people to? Who can you send them to for support and resources? So the first thing I tell providers is to understand what resources you have at your own institution. Do you have a social worker who might be able to help? Because remember, social work is not just about transportation. Social work is actually counseling. It's psychosocial, and we oftentimes don't use our social workers to the top of their licensure. And so there's an opportunity there. Do we have a sexual health clinic at our center? That's another resource. So identifying what resources you have available at your institution is always, from my perspective, the number one. The number two thing, let me just say, there are some resources online, and you mentioned you all had developed this online resource. There's a lot of information from patient advocacy groups that is phenomenal. And I'm just going to point out one. There's a group called Living Beyond Breast Cancer. I happen to be on their medical advisory board.
Me too.
Okay, so you know LBBC. So I think they have a fantastic entire cadre of information around sexual health. It talks about sexual health and intimacy in partners, how to have conversation with your partners. There's actually a wonderful provider there, Dr. Sage Bolt. I'm not sure if you saw her video that she has, where she's actually talking to a room full of women who have had breast cancer and talking about the impact of their disease on their sexual health, how we interact and think about our bodies and interact with loved ones. I loved it. I thought it was fantastic. So I just want to point out that as one resource. The other thing to mention is, I have another podcast, so 3 Black Docs podcast. We talk about all sorts of topics, and we oftentimes will have guest speakers, survivors, come and talk about the things that they went through and some of the resources that they had. So sometimes it's just, particularly for communities of color, the reason why we did 3 Black Docs is because we wanted Black individuals, Black families, Black communities to know that there is a way to talk about this big C word, cancer, in a way that doesn't have to provoke fear, but sometimes having the conversations before there's an issue is important, right? We do this kind of planning in other areas of our life, but oftentimes when it's health, we don't. And so we wanted to create that resource, the Three Black Docs podcast, and it's available everywhere for communities, for families, particularly the Black families and communities, to know that they can go and have conversations about health and well-being that may oftentimes be a little weird, but it's important. And we share our personal stories. Look, I talked about my colonoscopy and how that was, just because we want to make sure that people know that these topics, while sometimes can evoke fear or they seem taboo, it's important to talk about them.
That's fantastic. And I'm going to tune into your podcast next. But today on this podcast, we've talked with Dr. Karen Winkfield about sexual health and opening the door with just a conversation so we can either address it with the patient and or plug them in with resources either in their cancer center and community or beyond on the internet or through advocacy groups. Thank you so much for tuning in. If you haven't done so already, take a moment to download the Medscape mobile app to listen and subscribe to this podcast series on cancer survivorship. This is Dr. Ann Partridge for In Discussion.
Thanks for listening to Medscape's In Discussion Cancer Survivorship podcast series with our host, Dr. Ann Partridge. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on cancer survivorship.